Welcome to AETCM, the emergency medicine channel. Today, let us discuss about atrial fibrillation. So, when we discuss about atrial fibrillation, we should know what is a normal sinus rhythm. Normal sinus rhythm in ECG is a P wave, then PR interval, QRS complex, SG segment, T wave. This is a normal ECG complex where the P wave is produced from the atrium, QRS is produced from ventricle. Now, next beat has to come. So, in sinus rhythm, next beat has to come. PR interval has to be regular. QRS complex comes. Then T wave comes. Then next P wave comes. PR interval, QRS complex come. Then T wave. So, if you take the RR interval, that has to be equal. And if you take PP interval, that also has to be equal. So P wave should come regularly, PR interval should be normal, and QRS complex should come after every P wave. Then RR interval should be equal. Then only we can tell the ECG rhythm is in sinus rhythm. Whereas in atrial fibrillation, P waves you may not see at all. Then QRS complex come. Then some P wave, irregular P wave. Then one QRS complex. Then one QRS complex. And one QRS complex, one QRS complex. If you see the RR interval will be totally irregular. So that is the most important feature of atrial fibrillation. In ECG, if you are seeing RR interval totally irregular, or sometimes we call it as irregularly irregular. If you see the pulse in this patient, so you can see here QRS complex is coming irregularly and irregularly. If you see the pulse, that also will be irregularly irregular. So that is very important. Now here what is happening is normally atria beats in a rate of 72 or 75 or maximum 100. That is regularly atria beats. But in atrial fibrillation, that beating rate will be around 600. So here it is maximum 72 or 100, for example, maximum. Here it is 300 to 600 beats per minute. So 300 to 600 beats or 300 to 600 times cardia or atria produces electrical current. Normally, one current when it is produced in sinus node, that will go to the AV node, SEN node, AV node, then bundle office. So one will be transmitted to, one is produced here, one is transmitted to ventricle. So one P wave, one QRS complex. So here what is happening, 600 times atria is beating. All the 600 beats are, if they are transmitting to ventricle, then ventricle may beat at the rate of 600 instead of 70, 10 times more. Then the output will be completely reduced because ventricle need to get some time to relax, then only it can pump. So here if it is instead of 70, if it is becoming 600, then there will not be any pumping at all. So that is a problem in atrial fibrillation. So body has some control mechanism, it may control here. So it may control here so that out of 600, only 100 or 150 in a irregular fashion may go to ventricle. That is very important. So atria beats in a rate of 300 to 600. That 600 may not go to ventricle. Around 100 140 beats may transmit to ventricle. Then ventricle will pump in a rate around 100 to 140. That will be in a totally irregular manner. See, if you see the RR interval here, it is totally irregular, irregularly irregular RR interval. So that is the most important thing in atrial fibrillation. This is atrial fibrillation, this is atrial flutter. In both conditions, there will be slight atrial fibrillation, it is completely irregular. But atrial flutter, it is more or less regular, but not like a normal sinus rhythm. Now here what you are seeing is normal sinus rhythm, P wave, QRS complex, T wave, again P wave, QRS complex, T wave, RR interval is equal. Here if you see this RR interval is larger, this is lesser than the previous one, lesser than the previous one, this is very large. So totally irregular. If you see the baseline, it is wavy Okay, wavy baseline, that means no regular P wave. Since there is no good contraction in atria, it will not produce any proper P wave. It will be completely distorted. That baseline will be completely irregular. Now, if you see the classification of atrial fibrillation, there are three important classifications. Paroxysmal, that you know, paroxysmal, the word meaning is spontaneous or sudden. So, episodes of atrial fibrillation that starts suddenly and within 7 days mostly disappears. On most of the condition, it will be less than 24 hours. Persistent means episodes of atrial fibrillation at least more than 7 days may require either pharmacological or electrical intervention to stop the atrial fibrillation. Permanent AF is very long time patient is having atrial fibrillation. You might have controlled the rate with beta blocker or diltiazem or some other means. You are controlling the heart rate. Patient is stable, but still the rhythm is irregular, but in a controlled manner. This is more than 1 year. So there is a classification. So what are the causes for atrial fibrillation? Almost all causes of ischemic heart disease, hypertensive heart disease, congenital heart disease, cardiomyopathy, cardiac failure, whatever cause is there to produce damage to heart, that can produce uh, uh, atrial fibrillation, especially when the atria are enlarged. Conditions where the atria is enlarged, this can produce atrial fibrillation. There are some non-cardiac conditions like thyrotoxicosis, pulmonary embolism, COPD, hypoxia, alcohol. All these things are reversible causes, that extra cardiac reversible causes. They're very easy to control. Suppose the patient is having thyrotoxicosis and atrial fibrillation, very easy to control that. You can easily control the problem and it can be reversed. Now, lone atrial fibrillation means there is no other cause for atrial fibrillation. Without any cause, that means charge was score, that we will see afterwards. The score is 0. There is no other cause and patient is having atrial fibrillation. You call it as lone atrial fibrillation. Whereas in a patient with valvular heart disease, it's not a lone atrial fibrillation. Valvular heart disease like mitral stenosis or mitral regurgitation or ASD is a problem that also can produce atrial fibrillation, or alcohol-induced atrial fibrillation. They are not lone atrial fibrillation. Without any cause, if the patient is developing atrial fibrillation with charge was score of 0, then it is lone atrial fibrillation. Now, what is a symptom? The most important symptom is, we have already seen that atria is beating very fast, ventricle also beat very fast, but it is irregular. When it is beating, ventricle is beating very fast, the problem is ventricle is not getting good diastolic time. If the diastolic time is reduced, then when the diastolic time is reduced, the relaxation of ventricle is reduced, so that the amount of blood accumulates after the diastolic phase will be also reduced, so the pumping will reduce. So fast ventricular rate reduces the ventricular output, that produces fatigue, syncope, angina, cardiac failure, palpitation. Then suppose atria is beating very fast and atria the movement is not proper, the contraction is not proper, then there is a chance of accumulation of blood in the atria that produces mural thrombus. This thrombus can from atria can go to ventricle. From there, it can go to the blood supply to the brain or somewhere else. So thromboembolic phenomena are very common. Subclinical AF also can be there in some patients. They don't have any major finding. Only when they have a problem, like suppose the patient is having anxiety, fear, or they are on exertion, the atrial fibrillation will become a real problem in that type of patients. And they also can have some palpitation. Now, what are the signs of atrial fibrillation? We have already seen irregular pulse. Apical impulse you can palpate the apical impulse, but sometimes the quality of apical impulse will be varying. Apex pulse deficit, that is more than 10 beats. So all the beats which you are getting on the heart may not be transmitted to the peripheral pulse. That's why apical impulse with pulse, there is a deficit. Varying intensity of first start sound, because the amount of blood in each cycle is different from cycle to cycle. So the closure of the valve also will be varying. So that can reduce the intensity, can reduce or increase. absence of waves in JVP, disappearance of pre-systolic accentuation if there is a mid-diastolic murmur in conditions like mitral stenosis. That is also very important. Then hypotension also can occur because the output is reduced. But in that, most important thing is irregular pulse. That is the most striking phenomenon. If you connect the ECG or monitor, you can see irregular coming QRS complexes. Since the heart rate is very high, you can even get hypotension shock. So there are two important things. Atria is totally irregular. Ventricular rate is very high. That's why patient develops hypotension. Diastolic phase is reduced. That reduces the output. Now, what ECG shows, that is very important. Textbook says that you have a wavy baseline, then QRS complex, then wavy baseline, QRS complex, then wavy baseline, QRS complex. But RR interval is totally irregular. But most of the time, what you see in ECG is this wavy baseline will not be very visible. You get a straight line, then QRS complex, then a straight line, QRS complex, then straight line, QRS complex, QRS complex, QRS complex, QRS complex. And what is a striking thing in ECG? It is irregular RR interval. So that is the most important problem in atrial fibrillation. If you are seeing QRS complex are coming irregularly, then that is atrial fibrillation. So very important thing is atrial fibrillation. In atrial fibrillation, irregular QRS complex. Then tachycardia is a striking feature. If you have atrial fibrillation with tachycardia, in emergency room, it is very difficult to control the fibrillation, but you can easily control the rate, because rate control is very important in atrial fibrillation than controlling the rhythm. Rate control, because if the rate increases, whether it is supraventricular tachycardia or in atrial fibrillation, if the rate increases, that can reduce the output and it can produce hypotension and shock. So what are the investigation you do? Normally, any patient come with chest pain, palpitation. We do cardiac enzymes, BNP to rule out cardiac failure, D-dimer to rule out pulmonary embolism. Depends on the scenario only we do all these tests. Thyroid function test, if you are suspecting hyperthyroidism, then digoxin level should be done in a patient who is having cardiac failure with atrial fibrillation, and on digoxin level should be checked, because digoxin it's a pro-arrhythmic drug, at the same, it's a anti-arrhythmic drugs, but it can also act as a pro-arrhythmic drug. Toxic screening because of the suspicion of alcohol, chest X-ray, ABG, oxygen saturation. Echo is mainly done to see whether the chamber is dilated, or you can sometimes see the thrombus in the atrium. For that, trans-esophageal echo will be better. Then Holter monitoring should be done in paroxysmal or subclinical AF. In that, you can pick up the atrial fibrillation. Now, what are the complications? We have already seen the most important complication is tachycardia, reduced diastolic phase, reduced output, cardiac failure, hypotension, shock, syncope. So the most important thing has to be in emergency room has to be the targeting on the control of the heart rate. Then cardiac failure, pulmonary edema, you can treat with Lasix. Angina, that is also because of tachycardia. Embolic stroke is a very important complication of atrial fibrillation. So you need to see whether the patient is having mural thrombus, and long-term patient has to take warfarin or decoagulant drugs. Risk factors like more than 75 years, history of stroke or transient ischemic attack, mitral stenosis, hypertension, diabetes, cardiac failure, left ventricular failure, left atrial enlargement size more than 5 centimeter. All these things are risk factors. Now, what is a management? Management is basically you are targeting some important things. One is we have to treat the underlying cause. Suppose the patient is having hyperthyroidism and atrial fibrillation. You have to control the thyroid release. That controls atrial fibrillation. Now, other important thing is the rate. The most important thing in emergency room is rate control. Rate should be controlled, because we already told that atrial fibrillation can lead to tachycardia. Tachycardia will reduce the diastolic phase. Diastolic phase is the phase where ventricle accumulates good amount of blood. If the diastolic phase is reduced, then the blood in the ventricle will come down. So that will produce hypotension and shock. So what is most important in emergency room is the rate. So controlling the heart rate in atrial fibrillation will be the most important step in emergency room. And after that, anticoagulation, because we already seen that atria is beating very fast and the beating will not be very powerful. Blood can stasis inside the have a stasis inside the atrium that produces clot there. From this clot, it may go to the ventricle. From there, it will go to the systemic circulation. So you have to prevent that clotting. Anticoagulation also required there. So control the rate is very important. To control the rate, you can use two important drugs. Either metoprolol. Metoprolol is a beta blocker, controls the rate. Diltiazem is a rate limiting calcium channel blocker. So both drugs you can give. 5 milligram bolus can be given. Here it is 0.25 milligram per kg over 2 minutes. Or instead of diltiazem, we can use verapamil also. Same action. All the drugs have got same action. If you want to control both rate and rhythm properly, you can go for amiodarone. So if these drugs are failed, you can go for this drug, amiodarone, or some doctors straight away start this drug depending on the clinical scenario. The problem with digoxin is a very useful drug, and digoxin is a anti-arrhythmic drug. You know that it's an anti-arrhythmic drug. At the same time, it can be a pro-arrhythmic drug. So nowadays we are not using digoxin for all purposes. Only if there is atrial fibrillation with cardiac failure. That is the only indication for digoxin nowadays. Or you can use digoxin in other type of cardiac failure without atrial fibrillation. It may improve the clinical scenario transiently, but long-term benefits are not there. That's why nowadays we don't use it. Amiodarone is a very useful drug in emergency room because you know that amiodarone can control the heart rate. Amiodarone also can control the rhythm, whereas diltiazem, verapamil, or beta blockers, they all control the rate. They cannot control the rhythm. But it is not the first line drug. It is only second line drug. There are some conditions we can use it as a first line drug also. That I am not discussing here because it will take longer time. So amiodarone can be used in patients as a second line drug in an emergency room, or there are some conditions you can use as a first line drug where the other drugs are contraindicated. So here it can be used as an infusion protocol. So atrial fibrillation, first drug will be beta blocker or rate limiting calcium channel blocker. If it is not getting controlled, you can go for amiodarone. If first line drugs are contraindicated or they are not effective also, you can go for amiodarone. Digoxin is a drug which can control the rate properly, but it should be used with caution. Only if there is cardiac failure, we should use this drug because that is the only indication nowadays. That is only because of its very high side effect profile. It has got a very narrow therapeutic index. So there is high chance of arrhythmias after starting digoxin, and that you should remember. And in atrial fibrillation, what happens is after starting digoxin, all these things, initially you know that the rhythm is very fast. You can see the rhythm is like this. And if you start digoxin or something, the rate slowly comes down. But in some patients, it is extremely low. In that, even if it is extremely low, the RR interval has to be irregular. That is very important. RR interval has to be very irregular. If RR interval becoming equal and bradycardia in a patient who is on digoxin atrial fibrillation, remember that patient has gone to complete heart block. So there is a very narrow difference between the complete heart block with digoxin and completely controlled ventricular rate with digoxin. The RR interval is still irregular in atrial fibrillation with severe bradycardia, whereas in complete heart block with bradycardia, heart rate is always regular. And anticoagulation, we have already discussed that that is required because the atrium is not beating properly. There is a high chance of clot formation in the atria. To prevent that, we have to give either heparin, that is a injectable form of anticoagulation, or go for warfarin. Warfarin alternatives are there, so that also can be given. And keep the INR between 2 to 3. That is very important. Whereas APTT is useful in heparin, that is 45 to 60 seconds. Low molecular weight heparin also can be used if you are treating the patient as a OPD basis. Heparin is a very cheaper drug comparing to low molecular weight heparin, but we need to monitor the APTT frequently, whereas low molecular weight heparin can be given OPD basis. There is no need of frequent monitoring of APTT. That is also an advantage. And all patients with atrial fibrillation, we have to start aspirin because atrial fibrillation can be due to ischemic heart disease. That itself, high rate itself can produce ischemia. So if there is a lesion that can propagate and produce complete block, so aspirin is very useful. But remember, mural thrombus as such will not be responding to the aspirin. That is mainly used to prevent the coronary artery disease. Now, newer drugs instead of warfarin, we have dabigatran, apixaban, rivaroxaban. All these things, doses are given. If dabigatran induce bleeding, you can give idarucimab, that is also dose is given. So these are the newer drugs that has got lot of advantage when we compare with warfarin, because warfarin has got n number of drug interactions. So many drugs can have interaction with warfarin. It can either increase or decrease the activity of warfarin, and it has got a high chance of bleeding. Whereas newer drugs has got lesser interaction, lesser chance of bleeding. But even then, since it is an anticoagulant, newer anticoagulant drug, there is a chance for bleeding. We have to be very careful when we start this type of drug. Charts VASC score. That is a scoring system to assess the risk factors for ischemic stroke in atrial fibrillation. I am not going to the details of that scoring system here, but if the score is 0, the risk is low. So if the score is 1, moderate risk, you have to start anticoagulations. 2 or greater, high chance, and oral anticoagulation is required. Depending on the scoring system, we need to adjust the dosage of the warfarin. Now, restoring sinus rhythm, already I have told amiodarone is one of the most useful drug in emergency room, because we have limited knowledge about other drugs, and some areas which is not available. These type of drugs are not available, but if they are available, they are the first line choice. Cardiologists mostly use this type of drugs in their area, but many areas it is not available. So amiodarone will be very safe drug in atrial fibrillation with fast ventricular rate. If they are not responding to beta blocker, or you are not able to give because of some hypotension, severe hypotension we cannot give, we have to go for DC cardioversion. That is a different issue. But amiodarone can produce some amount of hypotension, but not like beta blocker or calcium channel blocker. Now, restoring sinus rhythm, if the patient is having severe atrial fibrillation or features of instability, like patient is having chest pain, patient is having myocardial infarction, or patient is having hypotension, shock, where we are not able to give the drugs. Most important thing is hypotension, heart failure, or angina. Then you have to cardiovert the patient. So that is very important. After giving some sedation, you have to cardiovert the patient. Required energy levels may be 100 to 200 joules, and depending on the clinical scenario, it may slightly change, and repeated cardioversion may also be required. If the cause is due to hypoxemia, you have to correct the hypoxemia, and heparin should be given before anticoagulation, DC cardioversion. Urgent cardioversion is required in active ischemia, evidence of hypoperfusion of tissues, severe manifestation of cardiac failure, pre-excitation syndromes like WPW syndrome, where we cannot use beta blocker or calcium channel blocker. That can sometimes aggravate the problem. Now, radiofrequency ablation is available for persistent or permanent atrial fibrillation, which cannot be controlled with your routine drugs. That can also be tried. Now we have discussed about one of the important problem in emergency room, that is atrial fibrillation. The problem with atrial fibrillation is if the heart rate is very high, then only we should interfere in atrial fibrillation in emergency room. That is because the fast ventricular rate can produce all the symptoms of atrial fibrillation. If the rate is controlled, we have time, then rhythm control can be done by amiodarone or some other means, or we have to always investigate what is the reason for atrial fibrillation. Like suppose the person is having thyrotoxicosis, if you treat the thyrotoxicosis, the atrial fibrillation will reverse. The patient is having pulmonary embolism, you treat that, it will reverse. So that is the advantage of reversible cause of atrial fibrillation. If that's due to cardiac disease, then that has to be treated. Thank you.